Okay, we are recording this session, so please, as I said, don't use your microphones and don't turn on your cameras to avoid recording any personal identifiable information. I'm Jennifer Heiss. I'm here from the Plainfield Public Library, and we are pleased to partner with Astera Cancer Care for the Astera Cancer Classes series. Plainfield Public Libraries in Plainfield, New Jersey. Our website is www.plainfieldlibrary.info. If you have any questions about our services, you can email us at ref@plfdpl.info or call us at 908-757-1111, extension 112. So Dr. Schumann is going to be presenting on myeloproliferative disorders, polycythemia.
Polycythemia.
Okay, and others.
Yes.
And I'm sure that you will enjoy his presentation. He's presented for us before, and he is an excellent presenter. All right. I'm going to let Dr. Schumann take it away.
Okay.
I'm going to stop my sharing, and you're in control, Doctor.
All right, thank you. So yeah, myeloproliferative disorders, it's a long word, polycythemia and others. And of course, we are the Astera Cancer Care Group, and you don't see the word cancer in there because that wasn't one of the terms used for this disorder way back when they started calling it a myeloproliferative disorder. And I'll kind of define that a little bit for us as we get started. This is a topic that I enjoy talking about, and I would have to say enjoy seeing patients with. They're not super common. They occur in a couple per 100,000, but many times they do very well. And so because I'm an old guy, I collect these patients. So if you see them once and you continue to see them, and you see every year you have more and more patients with this disorder because the patients do well. Many of them in this group of patients have normal life expectancies or prognosis greater than 30 years. And so it's a pleasure to take care of people whom we can help and have good prognosis. So anyway, I also thought there was a lot of misconception about this condition. People are diagnosed with it, and then they go home to talk to their husband or wife, and they said, well, what did the doctor say? Well, I have this myeloproliferative disorder. They say, what's that? And I don't know. So he said it's something not to worry about. So I think maybe you could clear up some of the mysteries about this, and also create a few, because it's a very heterogeneous group of conditions that all have some things in common and a lot of things that are not in common. And sometimes it's hard to pigeonhole the diagnosis into one versus the other. So first talking about the myeloproliferative disorders. Let me get comfortable with this cursor. And there I am, back a few pounds ago. And we call it the myeloproliferative disorders for 20 plus years. That's what I called it. And more recently, I've been hearing it being referred to as myeloproliferative neoplasm, which certainly sounds scarier than disorder. So I thought we defined the terms a little bit in the beginning. And so first we'll start by an overview of what I plan to do today, an overview of the myeloproliferative disorders. It's a family of diseases. There's many diseases that are clumped together in this group. And we're going to talk about them as a group and then individually. And the second question is it a cancer? Third, we'll talk about the myeloproliferative disorders, how they are similar, each of the ones, that's why we group them together, and then how they are different. We'll talk about how you define it. There's this new thing called a JAK2 mutation. It's not really that new, but it's what has enabled us to understand the condition better. And one of the types of myeloproliferative disorders called polycythemia vera, where people make too many red cells. And sometimes it's hard to to be sure whether they have a polycythemia vera, which is a primary polycythemia, too many red cells, or secondary due to some other condition that's making the bone marrow produce too many red cells. And we'll talk about that a bit. And then some of the myeloproliferative disorders in depth. And I'm going to limit this to 4 of them. There are more. Polycythemia vera, which is the most common in the hallmark, essential thrombocytosis, which is too many platelets, myelofibrosis, which is scarring, and CML, which is chronic myelogenous leukemia. So those 4 types. You'll hear these again. So if I said them too fast or you're overwhelmed by the names, you'll hear them again. So myeloproliferative disorder, myeloproliferative neoplasm, we break it up into the name, myelo, which means of the bone marrow, proliferative, I think somebody's off mute, proliferative, which is to grow or multiply, according to Webster, by rapidly producing new tissue parts, cells, or offspring. So this is a bone marrow that is growing rapidly and producing new cells. And we used to call it a disorder, which is an illness that disrupts normal physical or mental functions, a very broad term. Now, again, being referred to as a neoplasm, which is an abnormal mass of tissue that forms when cells grow and divide more than they should. And these neoplasms can be benign or malignant. So the question is, this is a neoplasm. It is an abnormal mass of tissue. In this case, it's bone marrow that divide more than they should. Bone marrow that makes more blood cells than they should. And the definition of benignant versus benign is that a malignant neoplasm is an abnormal growth that spreads to other parts of the body or grows uncontrolled. And so since this is an uncontrolled growth, this is in fact a malignant neoplasm. It just has, in many cases, a very favorable prognosis. Blood malignancy. It's the organ that we're talking about is in the bone marrow and the blood. And that includes acute and chronic leukemias, myeloma, and this so-called myeloproliferative neoplasm. They grow uncontrolled to multiple areas of the bone marrow, or something called extramedullary, which means it can grow outside the bone marrow, and the actual abnormal cells can be in the spleen or liver or other tissues as well. So the myeloproliferative disorders, if we group them together, if we look back, and we're actually going to go back when I do polycythemia vera, we're going to go back in the 1960s in classifications, but here, 2008, where they had 8 different types. And again, the 4 that I was talking about, and I'm going to talk about mostly, are polycythemia vera, myelofibrosis, or chronic idiopathic myelofibrosis, chronic meaning having a long time, idiopathic means we don't know why. Essential thrombocytosis, thrombocytes are platelets, and those are high platelets, or chronic myeloid leukemia, which is too many white cells. And these other ones are very rare. We're not going to talk about them in mast cells, but there are other blood cells that are in the body, such as neutrophils, eosinophils, and mast cells, which can grow out of control. And these are probably not myeloproliferative disorders, but look like them. Okay, so in 8 more years later, they reclassified them and they dropped several of them out, but our big 4 that we're going to talk about up here are still the same. They added this one, this one, unclassified. Why is that? Because, well, and you'll see that sometimes when we see patients, we can't be sure. We know they have a myeloproliferative disorder. We know they have one of these things, but they can't kind of squeeze them into a hole that gives you this, this, or this. These things overlap a lot. Somebody who has polycythemia vera, usually too many red cells can have too many white cells or too many platelets. So when you really can't figure it out, we throw them into this wastebasket called unclassifiable myeloproliferative neoplasms. Okay, so these disorders, it's a family of blood disorders, multiple ones, in which excess blood cells are produced in the bone marrow. Too many red cells, too many white cells, too many platelets are the products of the bone marrow that are being made, and any of them can be elevated and be called a myeloproliferative disorder. we're going to see later that it can be associated with this mutation that's in the stem cell. That's what makes it into an abnormal cell. We see mutations in other body cells that lead to cancer, malignancies. This happens to be a mutation that occurs in the stem cell that makes blood. And these are some of the mutations. We're going to talk about JK2 more in detail, not so much these two, and a little bit more about the BCR-ABL later. But those are mutations that contribute to myeloproliferative disorder diagnosis. Okay, oh, this slide got a little foggy on me, but you can probably see what I'm talking about. The stem cell. Stem cells are in the news all the time. We talk about pluripotential stem cells. These are stem cells, there's research being done in it. Adults have stem cells, embryos have stem cells. The pluripotential stem cell is a stem cell that can divide into any other tissue type in the body. In this case, it's going to be becoming muscle and nerve and other things. But we're going to talk about just the stem cells that can become blood cells. They can reproduce and then they differentiate or change, become more mature and become the mature cells. And in this case, these are red cells and these are platelets, and these are being made in the marrow. And on this side is the white cells. These are granulocytes, more white cells. These are lymphocytes. So now we're down here. This is a cell that becomes, that reproduces itself, that develops a mutation and leads to too much growth of white cells, these type of white cells called granulocytes, red cells, and platelets. Another way of looking at it, the marrow has in it hematopoietic. Those are bone marrow stem cells that can go into red cells, white cells, or platelets. So if you look at the myeloproliferative neoplasm, we talk about them all as a group, but now individually. The four types that I mentioned before, you see a predominance of one of the three types of cells: red cells, white cells, and platelets. The red cells, when you have predominance of red cells as the abnormality, it's called polycythemia vera. The predominance of white cells, abnormal white cells, is called CML, chronic myelogenous leukemia. White cells in the bone marrow or the bloodstream that are abnormal, particularly bloodstream, are leukemia. Or in essential thrombocytosis, the abnormality is too many platelets. The fourth one is myelofibrosis. So this is a little bit of an oddball because what you have here is active, what we call fibroblasts. There are not cells that are made in the bone marrow to reproduce. They are in the bone marrow that cause scar tissue, and these scarring replaces the bone marrow. So why does this belong in this group? Is because these patients can go on to develop myelofibrosis. The first three, polycythemia, CML, actually polycythemia and ET, can go on to develop myelofibrosis. In addition, each of these cells associated with each of these diseases associated with the mutation, you see the same mutation in myelofibrosis. So it belongs in this clinically, in this group. But again, each of these cells, each of these conditions behave different than each other. And that's why we kind of lump them together. And this is why we have that other one called unclassifiable, because some of them just overlap. I mentioned the other ones, eosinophilic leukemia, where the abnormal cells are eosinophils and the type of white cell that's involved in allergy. And this is the unclassifiable. So that's how the myeloproliferative disorders all fit together as a group. Now we talk a little bit about them individually. I wanted to kind of start with polycythemia vera. Polycythemia vera, the patients don't come to you with a tattoo on their head that says, I have polycythemia vera. They come to you with a complaint. and in some cases, when you're a specialist, laboratory abnormalities. And we have to make that diagnosis based upon what we see in front of us. And I'm going to talk a little bit about a hormone called erythropoietin, and we're going to talk about something called JAK2. So we're going to go to a little basic science so we can understand how we diagnose this condition. But also I'm going to talk about polycythemia, why it's bad. Why is it bad to have too many red cells? Well, this is called blood viscosity. That's the thickness of blood. And it's measured in an interesting device called a viscometer. Anyway, if you see here, we're talking about the viscosity, how thick the blood is, and the hematocrit, which is number of red cells. And you see as the number of red cells, the hematocrit, goes up from 20% to 40% to 60%, the viscosity goes up. The blood gets much thicker, and particularly between 40 and 60, it starts to go up. Imagine what it might be here at 70. You can't even see it, it's too high. And the viscosity of water is 1. So normally, even here, the blood is thicker than water. I think we've heard that said before, haven't we? Blood is thicker than water. Syrup that you put on your pancakes is about 2. Viscosity of 2. So you see that the viscosity is thickness. And I like to describe it as what you might see with pea soup. If you have pea soup and you have 40% of the soup is made out of peas and the rest of it is water, it's a certain thickness. If you add more peas to it, the soup gets thicker. Just like as you have more red cells in the percentage of red cells in the blood gets thicker. So why is it bad to have thick blood? Well, because the thicker it is, like mud, the thicker it is, the harder it is to pump. And if you think of the pump you might have that's pumping water, and now you ask it to pump thick mud, you're putting more stress on the pump. And what's the pump in our bodies is the heart. So it's not comfortable for the heart to pump thick blood around the, It's not comfortable to pump thick blood around. In addition, we worry about blood clots. And so if you're pumping thick blood around, you have a higher chance of having poor circulation. It would lead to poor vascular oxygenation of your tissues, and that leads to an increased risk of strokes and heart attacks because of the thick blood. So it's not a good thing, and that's why we like to bring it down. The second concept we were going to talk about, or the next concept, was erythropoietin, the hormone I had mentioned. A little background on that so we can understand why it is that and how it interacts with the diagnosis of polycythemia vera. Erythropoietin is a hormone that's made by our kidneys. And it's the hormone that stimulates the bone marrow to make red cells. It doesn't stimulate white cells or platelets, just the red cells. So the kidney, when it senses that you are anemic, will pump out more of this hormone and stimulate the bone marrow to make more blood. So if you take a young soldier who is shot and losing blood, and the kidney recognizes that anemia, it'll start making erythropoietin to make the blood come back to where it should be normally. And then when it gets to normal, it should shut down the erythropoietin excretion so that your body doesn't go too high. However, what happens if the kidney is fooled? The kidney responds to the low oxygen because of poor red cells. And if it thinks that your blood count is low because you're not providing the kidney with enough oxygen, why might that be? Somebody has bad lungs, smoking, a heart problem, but we'll go into some of these. It will continue to make the erythropoietin at a higher level, and your red cells will go too high. This is what erythropoietin looks like, so I'm told. I've never seen it myself, but this is how it looks. And here it's again, just as an illustration of what I was talking about. The bone marrow makes the blood, the red cells. The red cell production is recognized by the blood through the bloodstream, goes to the kidneys. It recognizes that the blood count is high or low, and it excretes this hormone, erythropoietin, into the bone marrow to have it make more red blood cells. So if a patient, because the kidney thinks that the person's anemic, has high erythropoietin level, the marrow is fooled into thinking the patient is anemic when the patient isn't. And this is called secondary. The bone marrow is normal. It's doing what it's supposed to do. It's just that the erythropoietin levels are too high. And it's functioning the way it's supposed to. What happens if the patient has a low erythropoietin level or normal one? The marrow should not be making the blood. It's not getting the stimulation to do so. But in the case of polycythemia vera, the bone marrow continues to make the blood despite the fact that there's no stimulation for it. It keeps going without regulation. So in this case, the bone marrow is the problem. That's polycythemia vera. Again, illustrating the same thing. Polycythemia vera, polycythemia rubra vera, and comes by a couple of different names. Rubra meaning, I guess, red, and it has to do with the way a person's face is. That's how it was originally described. And I thought I'd look this up to see who described it. It's called Velasquez disease, also Velasquez-Osler disease. William Osler is a giant of the turn of the century. This guy Vasquez, I had not heard of, but there he is. Since we're talking about it and since he described it, we should show you a picture of Louis Henri Vasquez. Very happy looking guy from France. While we're looking at pictures, I wanted to look at this, and I misspelled Phyllis's. No, I think I cut off the bottom. Phyllis George. Gave a talk months ago on pancreatic cancer. There was a time when Ruth Bader Ginsburg had died from it. Several other people, Alex Trebek had it. And I said, went through the list of people, you could look it up, who had pancreatic cancer. There was a long list of famous people that you could relate to. So I decided to look to see who may have had polycythemia vera as listed as a celebrity and had it. And I found out that Phyllis George, who really died relatively recently, died of what they said was polycythemia vera. I want to say, my goodness, she's only 71. This was a former Miss America. She was a sports announcer. She was the first lady of, I think, Kansas. Husband was the governor. She recently passed from this condition. My guess is she probably passed from complications of the development of myelofibrosis secondary to this condition. But she had it for 37 years that she had diagnosed. So she's obviously diagnosed at a very young age. There's probably a lot of folks out there who've had a myeloproliferative disorder. We just don't know about it. There's one other guy who is actually, and because I'm showing pictures, I'm going to show him too, who has a myeloproliferative disorder that you may also recognize. Certainly if you saw him in a crowd, you would. This is Kareem Abdul-Jabbar, who's had a CML, chronic myelogenous leukemia, for about 17 years and is spokesman for one of the drugs called Gleevec. And for this, he puts a lot of time in. He's very open about his diagnosis, and he's survived CML, chronic myelogenous leukemia, for many years. So again, just to reiterate, primary versus secondary polycythemia. Primary polycythemia is P. vera. The red cells are made independent of the erythropoietin level, as if the accelerator for making blood is stuck on. Patients have low erythropoietin levels because ones who have high erythropoietin levels have secondary polycythemia. And what happens is there's a bone marrow cell, the stem cell cells that make red cells. There's a receptor on there that are not working with erythropoietin hormone. They are working independent of the hormone, and actually can grow these cells in a culture, in a lab. And if you try to grow red cell stem cells in a lab, normal cells, you can't grow them unless you add erythropoietin. But if you add somebody's stem cells from polycythemia vera, you can see them actually grow without the presence of erythropoietin. This used to be a way in which we determine if a person had the disease or not. We see patients all the time. That's why I'm kind of dwelling on it, who have polycythemia and don't have polycythemia vera. They may be taking medication. One of the ones I see a lot of is people on testosterone, which can stimulate red cells to be made, and bodybuilders use it. So it's not uncommon for me a couple times a year to see a young man, usually, or middle-aged man, who looks like he's sort of pumped and pumping iron, and he's sent to me with a very high blood count, and sure as shooting, he's been taking testosterone. And we tell him to stop it, and many of them do, and their blood count returns to normal. So other causes of secondary polycythemia is high altitudes, called Monge's disease. Someone who's lives at above, goes and lives at above 15,000 feet, and the body senses your oxygen levels are low due to what they think the kidney thinks is anemia, and it's not. Pulmonary disease, having an abnormality in your heart that makes you not being able to oxygenate your blood. Heavy cigarette smoking. I see this all the time from low oxygen, but also from carbon monoxide. And so I can check a carbon monoxide level in someone, find it to be high, and that could lead to high blood counts. Kidney tumors. If the kidney is making too much erythropoietin on its own, and other kinds of tumors, we can see this. Those are pretty rare. That's kind of the same thing. Sleep apnea is added on this. Okay, now the other concept I wanted to talk about was a JAK2. This is called the Janus associated. In order to understand polycythemia vera, you got to kind of hear these terms. JAK2 is a Janus associated kinase. It's an enzyme in our body that leads to the production of the abnormal cells, the growth, I should say, the stimulation of this kinase leads to the growth of the stem cells and the production of the red cells. So that's the job of this particular protein, tyrosine kinase. And that's what that looks like. Looks like drawn by the same person. It's drawn the erythropoietin, but a little more complicated. It's a glycoprotein. It's more than just a hormone. And here's where it sits. The erythropoietin, which is up here, stimulates this receptor. It combines with it in combination with the JAK2, and the JAK2 signaling pathway activates proliferation of the blood. So the JAK2 is useful in the production of blood when the receptors are stimulated by the erythropoietin. So what happens with polycythemia vera? The JAK2 is mutated, and it makes the receptor will, independent of the erythropoietin, will cause activation of the cells and growth of red cells. So because of mutation in the JAK2, which works with the receptor, the erythropoietin is not needed to grow blood. And that's the problem with polycythemia vera. And so we see this mutation as one of the findings in patients with polycythemia vera that differentiates P vera from somebody who does not have P vera but has polycythemia for a different reason, secondary reason, and you look for the secondary reason. So here's an example of a man I saw, and as I said, the patients don't present with a diagnosis of polycythemia vera. They come in with signs, symptoms, and laboratories. And I actually saw this guy on May 17th, 2021. So just this month, 60-year-old guy, previously in pretty good health. Started noticing he had some gradual increasing tiredness. He had a blood count done by his doctor when he complained there, and the person had a hemoglobin of 21, hematocrit of 76. Remember what the viscosity looked at 60. This is even higher. So white count was a little bit high, 10.5. As I said, sometimes you can get some other abnormalities besides red cells. Increased basophils, which is a sign of this condition, and a platelet count of 519,000, which is above normal. 400,000 is normal. So he sent to see me for an evaluation. Didn't have any bleeding or bruising. He noticed he was itchy, another sign of this, and his blood pressure was high. He had developed a rash and redness of his hands and his face, and he complained of some fullness in the left upper quadrant. And so this is his blood count. Again, red cells were, and this is normal over in this column here. Red cells were greater than 8 million per cubic millimeter. Hematocrit, when I saw him, was 70, sky high. These just are describing the red cells. A platelet count was not quite as high, but was elevated here. And this is the size of the platelets. But the bottom line is, guy had extraordinarily high blood count. Very little else besides polycythemia vera can cause this. We did an ultrasound of his abdomen, and this is what it showed. The spleen was enlarged in size, as you see in 75% of these patients. He had some other things. His liver had some cysts, and gallbladder was okay. But basically, the main finding was the spleen was enlarged. So he did the blood test, and the JK2 was positive. So he has a mutation. So we know that this guy has polycythemia vera. The type he had was the most common one, called a V617F mutation. This is not him, but this is what I was talking about. There's the red face that a person can get, and kind of a red nose. You can get this probably from drinking too much too, the nose, but and maybe in the face. But this is the characteristic rubra face of a person with polycythemia vera. So we have to talk about then. Let's see what else I have here. How do you determine a person has it? In this case, I said we diagnosed it on the basis of his the JK2 and the high hemoglobin, but I'll put some thought into how we used to and currently define this, because we have to put people on treatment based upon being sure that they have the disease and not guessing. So I want to historically go back to something called the Polycythemia Study Group. This was actually formed in the 1960s, before we had erythropoietin levels and before we had JK2 levels we could check. And they wanted to decide the best way to treat people. But before they knew could determine how to treat them, they needed to be 100% sure, as best they could, be sure that the patient actually had it. So they came up with criteria to be included in the Polycythemia Study Group. And this defined for 20, 40 years who had polycythemia and who did not. And so again, the design was really to find out what the best treatment was, and the three ways they treated them once they decided they had it was to either take away blood, phlebotomy, give them radioactive phosphorus, an old treatment, or use this drug called leukeran, which is chlorambucil, or one of the earliest chemotherapy agents that we had. It's a pill. And to be included, you needed they grouped this into two groups of risk factors. One is that they had an increased red cell mass, and this means polycythemia. They would measure how many red cells were in a person's body using a chromium labeled technique. We don't do that anymore. They don't even make the kit. Person had to have normal oxygen saturation. Remember, if somebody has low oxygen, you get a secondary polycythemia. And so you had to have a good oxygen, and 75% of patients had enlarged spleen. Group B was an increased white count, greater than 12,000, increased platelets, increased B12, and increased something called LAP. required 2 in group A. I'm sorry, all 3 in group A was enough to be included, or 2 in group A, the first 2, and 2 in group B. So you see how common it is to have other things besides increased red cells. And they looked at the best treatment. And so one treatment was the phlebotomy, where you just took blood away from people. The second, radioactive phosphorus. The third, this pill called Leukeran, alkylating agent. So the results of this, which were published in, it was again, that started in the 60s and it was published probably in the early 80s, 40 years ago, was that everybody did about the same, except that the patients who had this condition died of different things. People who had phlebotomy alone, they had an increased risk of heart disease. Radioactive phosphorus, some heart disease, but more leukemia. And Leukeran, these patients had an increased risk of developing leukemia as a complication. Well, you know, what do we do about this when we learn more about it is, by the time this was published, there was a better drug called hydroxyurea, which is not an alkylating agent and doesn't cause leukemia. So that became a standard treatment. Still use this occasionally. In the phlebotomy, virtually all patients with polycythemia vera are placed on baby aspirin, and that eliminated a lot of the problem with the phlebotomy. In addition, the phlebotomy patients sometimes had an increased platelet count, and that contributed to increased clotting. So instead, we use this hydroxyurea pill, doesn't affect the DNA, works on the RNA only. It's called a ribonucleotide reductase inhibitor. And because it doesn't work on the DNA, it's why it's not leukemogenic. And its side effects are mostly hematological. It can decrease the white count, and you have to monitor it. Occasionally, I've had a couple of patients who had trouble with their skin or some intolerance of it in the GI tract, some nausea from it. Typical labs in polycythemia vera, 73% in one particular group where there's 400 patients in a group. The hematocrit was greater than 18 and 73%. The white count was elevated in half. Platelets were greater than 450 in half. They had a high LDH. The JK mutation that I had mentioned before was 98%. That's why this is such a good marker for it, and why most of the time we say to patients, if you have a JK2 mutation, you definitely have polycythemia vera, that we know for sure, or you have a myeloproliferative disorder. And the low erythropoietin level is 81. But if you're negative for the JK2, it's probably unlikely. You probably don't have it. But we can't be sure because there's still maybe 2 or up to 4% of people who still have it. And so again, the low erythropoietin level, it also helps to define it as a primary versus secondary polycythemia. It's pretty good, but not quite as good as the JK2. So again, in summary, the polycythemia vera is a relatively uncommon disorder. It occurs in perhaps 1 to 2 in 100,000 patients it's diagnosed in 1 or 2 of 100,000 patient population, but because the prognosis could be 30 years or more, you develop a practice with more and more patients over time. At least an older doctor does. Diagnosis depends upon your knowledge of erythropoiesis. That's why I went into it, because you have to rule out secondary polycythemia. The complications can occur from thrombosis and vascular incidents, or from developing leukemia in long term. So now, 2016, fast forward 50 years, the criteria have changed. We don't use the polycythemia study group. Now we diagnose with a hemoglobin. The hemoglobin is greater than 15, 16.5. I'm going to say that most of the time I'm using 17. The JK mutation is found, the V17F or the exon 12, which is less common. This is up to 98%, some studies 99%. And the minor criteria, if you're the 2% here, is a low erythropoietin level. So in order to make a diagnosis, you need to have all 3 major, or 2 plus the minor. So that's kind of how we diagnose these patients and say, yes, in fact, you do have polycythemia vera before we we will put them on medication for this. That's again the review of what we used to have. Let's go through this. Aspirin is all the patients are placed on aspirin because it lowers the risk of heart attacks and strokes, and just mini doses enough, unless the person is a cardiologist and wants some higher dose for other reasons. But for just polycythemia, aspirin is enough. And I mentioned the bone marrow, and I thought I'd show a picture of the bone marrow. This is a normal bone marrow on the right-hand side. What you can see is these globules. This is fat. The bone marrow is made up in a person 50 years old, 50% fat, 50% marrow. And these big cells are megakaryocytes. And this is, you see the white cells and whatnot. Polycythemia vera. These are the, you see, the fat is eliminated. Why? Because the bone marrow is being stimulated to make more blood, and the fat is pushed out. In addition, you see these are the red cells being made. There's more red cells being made. And these guys are the megakaryocytes. Again, they're making platelets. So you see increased platelet count, particularly in this patient. And the bone marrow looks like this. But do I do a bone marrow in all patients with polycythemia vera? The answer is I don't, because it doesn't add a lot. If the patient has a high count and has this JK2 mutation, they have polycythemia vera, particularly if the erythropoietin level is low. And showing the bone marrow with increased cellularity, to me, doesn't add anything in the diagnosis. So I don't see how we can't make the diagnosis with just the 2 major and 1 minor. And I think many, if not most, doctors will agree. Okay, how about better treatment? What about the patient that can't stand the hydroxyurea? We have a new class of medications, and this is called the JK inhibitors, Jakafi. They got JK right in the name. This is the first one, came out several years ago. And this is a medication that works like this. Again, if you remember this receptor and the JK, the kinase, the enzyme that works right here, and that's a normal signaling. Here's a patient with polycythemia. They have overactive signaling. The erythropoietin is not in there. It's making the signal here. JK2 affects this kinase, this enzyme, and lowers the signal so that there's less of a signal to make red cells. So the normal situation, polycythemia, go on medication to cut back on the signal so that the patient has a normal amount of signaling and the blood count will come down. Why is it good to, again, to bring it down? Is to avoid complications, side effects, long-term side effects of Jakafi. We don't know them all because the patients haven't been on it 50 years like hydroxyurea, but so far we have not been seeing increasing leukemia. Okay, so that it's Jakafi is right. Ruxolitinib, it's a Janus kinase JK2 inhibitor. And it's indicated at the bottom, cases of person who doesn't respond or cannot tolerate hydroxyurea. It's also indicated in myelofibrosis, which we're going to go into further down. That's another indication for it. Jakafi, new medicines are expensive. And just put this up to tell you how expensive it is. A 5 milligram tablet costs a supply of 60, which is a 1 month supply, costs about $15,000. $15,000 a month to be on this medication. Insurance does pay for it. That's why you want to have the indications. Sometimes the copay is high, and there's almost always very good copay assistance. I've had patients, maybe 8 or 9 patients on that. I haven't had a single patient that could not afford it because of inadequate coverage. The company does supply it for free, and people who are not Bill Gates or equivalent. I guess we don't say Bill Gates anymore. We say um, Jeff Bezos. So it's not the only drug in the JK2 that's being made. These are the drugs that are already approved. Some of them are for polycythemia and vera and myelofibrosis, and some of them for other diseases where the JK2 kinase is important: psoriasis, rheumatoid arthritis, dermatitis, and others. So I just thought I'd bring this up. Those are approved drugs that are JK2 inhibitors. All new. Xeljanz is being advertised for rheumatoid arthritis on TV. And in clinical trials, these are all the ones, these are all JK2, also JK inhibitors for myeloproliferative disorders, atopic dermatitis, lymphoma, pancreatic cancer, lupus. They're all being evaluated. So that's enough on polycythemia vera. I just want to quickly go over and then go through some questions on the other ones. This is thrombocythemia. So we had mentioned before that the myeloproliferative disorders are associated with increasing red cells, white cells, and platelets. This is the condition where predominantly the problem is too many platelets. The actual cause of this is not known. It doesn't work like polycythemia vera. There is a hormone called thrombopoietin that works like erythropoietin to stimulate the platelets that's in the liver, but it's not as if we have worked out with a receptor because only half the patients have this mutation. Although some have a different kind of mutation, some called CALR or MPL mutation, less of them have. Women more likely to develop this than men. This little older population, same amount, 1 to 2 per 100,000. It's more common in African Americans. And as I said, there is the thrombopoietin, which is made in the liver, not the kidney. But patients with central thrombocythemia sometimes have high levels of that hormone, not low levels. So it's not quite the same. These patients have high platelets. They don't have any symptoms. They don't have red face. They don't have thick blood per se. Viscosity, they have just a routine blood test, usually showing a high platelet count. And in one group where there was 250 cases in one institution, they had an average on diagnosis platelet of 1 million, with normal being anything abnormal being over 400,000. White count was on average high. They did not have a high blood count, red cell count. Their spleen was enlarged 35% of the time. They had blood clots as a major problem and bleeding. So these patients, because of high platelets clot blood, have an increased risk of clotting up to 22%. And when really high platelet counts are found, they have this thing called acquired von Willebrand disorder. They lose clotting factors that can make them have increased bleeding. So 26% of people have bleeding events, not just clotting events, despite having high platelets. We actually see some young women, that a population of this, and it can cause, because of high platelets, 45% of them can lose a baby in the first trimester if they're pregnant. So what do we do with the high platelets? Well, we can take away red cells, but it's a little hard to take away platelets. We put them on medication for this. When do we put them on medication? History of clotting, older, risk factors for clotting, or if they have the JK2 mutation, the 50% have a higher risk of clotting. So we put them on medication for this as well. Again, these are major and minor criteria for essential thrombocytosis. Major criteria are high platelets, and they don't have something else, those other conditions that can cause high platelets. And you can do a bone marrow, and you see a lot of megakaryocytes with fibrosis. And they have a mutation, then you know they have it as well. There's a lot of other causes of high platelets. Sometimes if the JK is negative, you look for iron deficiency, person who's lost their spleen, cancer, trauma, bleeding, and myelodysplasia. How do we treat them? Again, with high platelets, we put them on low dose aspirin to try to prevent a blood clot, a stroke, or a heart attack, unless they're bleeding. If they're bleeding, then you put them on aspirin and make sure they don't have the disease, and you bring the platelet count down. The life expectancy is close to normal. Average diagnosis, person lives 33 years. Average patient, if they're 60 years of age when they're diagnosed, puts it at 93, and that's close to a normal life expectancy. We treat them with hydroxyurea, similar to the medicine we use for Pivera. Some drug called anagrelide, I mentioned, used to use it, can't get it anymore, not making it. Although it is a drug, we don't like to use it. It causes increased scarring. And women cannot be on hydroxyurea during pregnancy. We put them on some interferon and aspirin so they don't spontaneously abort. The next disease is this primary myelofibrosis, another one of the myelodysplastic syndromes. Myeloproliferative disorders, myeloproliferative neoplasms. It's a little less frequent, only 1 in 100,000. The prognosis is worse. The patients have only a couple of years sometimes. We see it in older adults, average age of 67. They present with anemia, and that's why fatigue is an important symptom. The spleen is enlarged half the time because the bone marrow is being replaced and the bone marrow cells are going into other organs such as the spleen. There's weight loss, fever, bone pain, sweats, sometimes itch, and this is what the marrow looks like in this case. You usually can only diagnose by looking at the bone marrow for sure. On the left is a normal bone marrow. You see again the fat, the white spots, and that's the left versus bone. The right side is a fibrosis, a little coning down on it. You'll see that there's not a lot of room for bone marrow here because all the scar tissue is in there replacing it. So we find these patients with a big spleen, a large liver, and the reason for the big spleen and liver is because the bone marrow cells, in order to survive, are moving out of the bone marrow in the bones, and they're going into other organs. We find sometimes this extramedullary hematopoiesis in the skin and lung and other places. It's unusual. Let's skip it. And then again, the JK2 can be positive in 60 to 65%. So in other ways, another reason why these are linked together, these disorders. And again, myelofibrosis indication, primary or after having a polycythemia vera, you can use this drug. And it will decrease the spleen size, make them more comfortable, may for a time limit their need for blood transfusions. And finally, CML. This is the white cell version of polycythemia vera, except it's a different enzyme. Not the JK2 is a tyrosine kinase, but it's not this one that is being mutated, but a tyrosine kinase that's unique to a bone marrow problem called BCR-ABL. And I'll explain where this abnormal gene, which codes for a protein, comes from. It comes from when two chromosomes exchange material. This is a chromosome number 9, and a chunk of this piece of chromosome and a chunk of this piece of blue switch places. You see that by color, this becomes here and here. So there's an ABL on here and a BCR on this side, and so the two combination, now you have a BCR-ABL next to one another, and this codes for a unique protein, a tyrosine kinase, that will make the cell turn into a leukemia cell. And this was first found by Peter Knoll in 1961. He's a University of Pennsylvania pathologist, and he's the first time that they found a genetic marker for cancer. And this is near and dear to my heart because I was privileged enough to work in Dr. Knoll's laboratory several years afterwards when I was undergraduate at University of Pennsylvania, and we have a little paper here together, my name and Dr. Knoll's name, along with Barry Berger and Ron Danielle, on some obscure thing that is no longer of interest to me. So here we are, the fusion of two chromosomes, uncontrolled production of red cells, uncontrolled population of white cells, and untreated, it develops we call it accelerated phase, followed by a terminal blast phase in 2 to 4 years, and virtually everybody has this happen. It occurs in 1 to 2 cases per 100,000, average age 50, and we treat it with an inhibitor of that BCR-ABL that's been developed, called Gleevec. The response rate's like 96 to 98%. The question is, does that mean some patients come off it, half of them do not relapse, that maybe it's curable by using these pills? Otherwise, we do bone marrow transplants. And due in part to the development of this drug called Gleevec or imatinib, we see the prognosis from CML has increased from 5-year survival, 31%, 93 to 70% in 2016. And it led to this, and these are other agents. It led to this, oops, let me see. Doctor saying, starting from 2011, it became clear that CML patients have the same or almost the same life expectancy as the general population. That's amazing and wonderful for people who remember the past. And they're trying to make better ones. These are the ones that are now actually in being used, not just for CML, as you can see, several of these are CML, but for other conditions as well, melanoma, thyroid cancer, sarcomas, pancreatic cancer, et cetera. Everything's being studied. It's expensive. Costs about 8,000 to 9,000 for Gleevec, and Tasigna, which is a more potent version, it can cost $16,000 a month. Led Time magazine with developing this to say these are the bullets, and that's maybe why Karim Abdul-Jabbar, since he's on these medications and doing so fine for 13 plus years, is smiling. So thank you. Jennifer, I don't know if they have any quick questions we can answer.
Let's see, if you have questions, please put them in the chat box and I'll be happy to read them out to Dr. Schumann. I always wondered what Gleevec was for, because you see it mentioned on TV. Now I know.
Well, it's again one of those conditions where if you see one new patient a year, and if they have a normal lifespan, after 30 years you have 30 patients, don't you?
Yep.
So yeah, if you have 2 a year, and you have 60 patients, so it's nice. I get to know these folks real well. I think I maybe shouldn't say this. I recognize the name out there.
So if anybody has a question, please post it in the chat so I can pass it on
I kind
to
of
the doctor.
at the end there to leave a little room, but in time.
Yeah. Nobody has any questions?
Oh, I guess
Wow.
I understood everything or fell asleep. What can I tell you?
Well, it was very educational.
As I said, I enjoy dealing with these conditions. If one can think of a doctor enjoying dealing with any conditions who's an oncologist, but because of the favorable prognosis, the fact that you get people better, the fact that they have normal lifespans in some cases, on medication. I mean, and without their treatment, 20 years, 30 years ago, people would succumb to these diseases. It's a rewarding thing to take care of. Let's put it that way.
Okay, we'll have one last opportunity for the chat, and then we're gonna close the recording. Again, this has been Dr. Richard Schumann. Oh, sorry, we do have a question. Does TET2 affect PV? Sounds like med speak, so I'm not sure.
Does TET2
TET2 affect PV?
PET2. I don't know.
PET.
Does PET affect?
T as in Tom, E T. Does TET2 mutation affect poly,
I
polycythemia vera?
not that I'm aware of. I mean, I think I don't think so. I don't believe that's something I'm. Excuse me. That's not something I'm familiar with. It's not one of the certainly one of the mutations that I've seen that they refer to typically, and we don't send that out in patients with polycythemia vera. We do send for the JK2, the V617F, which is the predominant one, and then we send it called reflex. So if we have a strong suspicion of polycythemia vera, they do the 617 first, and if that's positive, they stop there. If it's negative, then they may look for a different axon, a different section of the JK2, or they look for the MPL or CLG. But going beyond that, or unless the TET is a code name for one of something by a different name, such as an axon 10 mutation, axon 12 mutation. They look at different sections of the same gene to see if there's a different, because not every mutation is the same, but could affect the same enzyme and cause it to malfunction. So I don't know about the T3.
Okay. Are there any other questions? Thank you everyone for attending. This is Dr. Schumann has spoken to us about myeloproliferative disorders, polycythemia, and others. Please join us on June 8th when Dr. Brian Canavan will be talking about understanding early stage and non-metastatic rectal cancer.
Oh, wow.
The tiny URL is here. And also, if you want to go to the library's webpage, there's a link for that in our calendar. And we will be posting a recording of today's presentation on our YouTube channel. Let me just pull up our webpage. And if you're interested, you can go to our YouTube channel, and under our playlist for adult programming, you can see colorectal cancer. That was an earlier presentation by people who are now doctors who are now with Astera Cancer Care. And feel free to ask us any questions, drop us an email, call us. Our phone number is 908-757-1111, extension 112, or you can email us at ref@plfdpl.info. Okay. Thank you so much, Dr. Schumann. It's been a very pleasure. It's very much a pleasure having you present for us.
Appreciate that.
Thank you again.
Okay.
All right. And we're going to stop the recording. Okay.